Alright, this is my Nurse 333 final checkoff. Alright, my name is Corbin. I'm a registered nurse in the state of West Virginia. This is my wife, Cassie Bailey. I also assessed her for the midterm. The final checkoff's a little bit different than that. We hit a couple different key points. So I'm going to go ahead and get some of my supplies. I have them on the table here that I have the camera on. And I'm going to go ahead and get started. First off, I'm going to go ahead and ask her a couple questions. What's your name? What's the year? Who's the president?
Catherine Collins. The year is 2013, and Obama's the president.
Alright, and see, now we can tell that she's alert and oriented times 3. Do you know where you're at right now?
Yes.
Where?
Rush, Kentucky.
She can also tell me where she's at right now. She verbalizes. I can tell. I obviously know her as well behind. She's alert and oriented times 3. She can speak well. She has good tone, good clarity, can express her needs easily. She can also verbalize her pain scale. Are you in any pain right now from a scale of 1 to 10?
No.
Okay, so she can tell me and verbalize how she does her pain. I'm going to go ahead and check her temperature. I have my little temperature gauge here. I'm going to turn it on. The normal temperature we can accept is probably about 97 to 98.6. Starts getting a little bit higher than that, it's a low-grade temperature, and then if it goes above 100 and 101, we're going to think something's very wrong. We think that there's an infection going on. I'll go ahead and stick this in her tympanic. And 97.8, that's acceptable. I'll take that. I'm going to go ahead and set this back down. I know her skin, it's pink, warm, dry. She has no open areas. I know her body fairly well, and she has no anything to be worried about, no bruising, ecchymosis, nothing like that of the sort. There's a couple different things that can happen with the skin. You know, we can get our growths, different kinds, cancers. We have warts, none of that, dry skin. We can have psoriasis, red skin, eczema. That's another one that's an immune disease that can affect the skin. I'm going to go ahead and check her eyes. I got to grab my flashlight real quick. I'm going to go ahead and check for reaction to light. I'm going to look and see if they're the same size right now, which they are. They're about 4 millimeters. I'm going to look and see direct and consensual. Direct's the eye that you have the light in, and consensual is the other eye also briskly dilating. So I'm going to go ahead and check that real quick. Just open your eyes for me, dear. Alright, they go down to 2. Okay, and it also does it. Let me check consensual now. They still? Alright, they both brisk, consensual, and direct. I'm going to go ahead and check for some movements and stuff. Follow my finger, please. Okay, it works to accommodation, a little squinting at the end, but that's to be, you know, expected sometimes. Some people have close time, maybe they're farsightedness, nearsightedness, astigmatism. Those are probably 3 of the most common things that affect Americans today. Now I'm going to go ahead and take a listen to the lungs. Oops. Alright, we listen anteriorly to the right upper, right middle, and the left upper. The left lung only has an upper and lower lobe. So I'm going to listen. Take a deep breath. Okay, that's clear. Good. Alright, everything's clear. I'm going to listen to the lower lobes posteriorly. Lean forward for me a little bit. Take a deep breath. Good. Alright, as I can tell, all lungs are clear. There's no sign of wheezes, rhonchi, or rales. Wheezes is usually heard during on inspiration and expiration. It's like a narrowing of the passages, either by mucus or maybe tightness caused by some kind of I've got brain track for a second, but it's some sort of I'm just going to forget about that, and we're just going to move on. I'm going to go ahead and lay my stethoscope down real quick. There's a couple different ways that we hear the bronchovesicular sounds about midway through the chest, and the vesicular sounds in the major airways. I'm going to go ahead and move on down to the heart with my assessment. I didn't hit on it earlier, I just wanted to mention it. The skin turgor, everything looks good with the skin. I didn't check the turgor, it responds readily. So I'm going to go ahead and listen to the heart. The S2 is heard best at the base of the heart, and S1 is heard best at the apex. I'm going to go ahead and take a listen to see if there's any other sounds heard, like an S3 or S4. S3 is characterized when there's no a synchronization of S1 and S2 and we hear an extra sound. S3 sounds like Kentucky and S4 sounds like Tennessee, 4 syllables and then 3 syllables. So I'm going to go ahead and take a listen at all 3 points. Alright, I hear no other sounds, no murmurs. Point of maximum impulse, it was tapping. It was located about the 5th, 6th intercostal space. She doesn't have any irregularities. I'm going to go ahead and check her pulse. Since we went ahead and checked that, I'm going to check it radially and apically. This is radial. I'm going to use an O2 sensor to help me do that. Her pulse is 76 and her oxygen is 98. Seems to be no problems there. So we've got a pulse of 96. And now I'm going to look at the clock on the back of the wall. Okay, I got about 42, 43, so I times that by 2 because I counted for 30 seconds. That'll be about 96, 97, so that's where it puts us at. I want to go ahead and look at the abdomen. We want to check a couple things in the abdomen. We want to check for symmetry, which we have. We have a nice symmetrical stomach. It's nice and flat. I don't see any aortic pulsations. You wouldn't see them unless you were laying down most of the time, but you can see it mostly in the midline of the abdomen area. I don't see any peristaltic waves. Sometimes that happens after having a big meal. You can actually see it flutter as the food is moving through the digestive tract. There is no ascites. The firmness, it's soft to palpation. Is there any pain while I'm feeling? So it's soft with no pain. I don't feel any masses. I wouldn't think she has any ascites, liver enlargement or any kind of fluid gain because, like I said, everything's symmetrical, everything's soft, nothing's hard, nothing looks out of the ordinary. Oh, goodness gracious. Okay, as we also look at the abdomen, we want to check for the Cullen's sign and the Gray-Turner sign. That would be bruising on either the front or the flank. There was neither of that. I've looked and assessed for both of those. Neither of those showed up. I want to go ahead and listen to the bowel sounds as I move down to the abdomen and make sure that digestive tract is working properly. We want to start off in the right lower quadrant because that's the closest to the sigmoid colon. Okay, bowel sounds are present in all 4 quadrants. You're going to listen for bowel sounds. The normal sounds is a clicking and a gurgling every 1 to 3 seconds. Anything below that would be hypoactive, and anything above that would be hyperactive. Diarrhea is most associated with hyperactive, and constipation is associated with hypoactive. We want to go ahead and move to the extremities now that we've got the trunk of the area. I want to go ahead and assess a couple different things. She walks. She doesn't need any kind of assistive devices to walk. She has no trouble. She has no syncope episodes, no unsteady gait, anything like that. I want to go ahead and check her hand strength, though, and her foot strengths. I want you to grip my hand, squeeze. Okay. Hands are equal strength bilaterally. Let me check the feet real quick. Push down like you're driving. Okay. Both are equal as well. I want to go ahead and check some pulses and make sure that they're, in the normal range. We go from 1 to 4, and I want to go ahead and check. Let me check some of your pulses here. This is the radial pulse. and it's brisk, and it's also it's about a +2. Brachial. Good strong beat. Good strong beat, all 4. I see no problems with any of her circulation to the upper extremities. I want to go down to the lower. We want to check out any kind of varicose veins or anything like that. There's none of those present. Go ahead and uncross your legs for me. Since we move on down, I want to go ahead and look. She has no edema noted, none at all. And when the edema scale goes from also 0 to 4, it goes 1 + 1 + 2 + 3 + 4. +4 is very major pitting edema, and it's usually associated with chronic heart failure. And if it gets +3 or +4, they're maintaining some major fluid, and we probably want to seek medical attention as soon as possible. I want to go ahead and talk about if you ever feel absent pulses, sometimes you have to use a Doppler to be able to get the beat. But if worse comes to worse, sometimes there may be a blockage. You can tell by this by maybe the bluing of the skin, it's a different temperature, things like that. That's associated with a blockage or any kind of thing that is worsening the circulation or anything like that is caused. I want to go ahead and check her out again. As I say, we move down the arms and legs, we want to check all the joints. All the joints are soft. Do you ever have any pain in any of your joints, in your arms or your hands, wrists? I don't feel any masses, no kind of tightness, no swelling is evident. All of them are good. No pain in the knees or the ankles? Occasional maybe?
Yeah.
Okay. Alright, after we check that, we want to go ahead and assess the range of motion. Will you put your arms out for me and just do some circles? Put them in front of you like this. She has full range of motion of the upper extremities. Just kind of move your legs around for me, left and right, up and down. Okay, full range of motion of the lower extremities. Like I said, I checked her hand grips and foot strengths earlier. The grips were good. We want to move down now to the musculoskeletal. Her level of consciousness is full. There's a couple different of those: stuporous, lethargic, coma. Lethargic usually means that they're drunk or maybe high on drugs. Stuporous means that they're kind of in a light daze, kind of like a coma, but we don't know what to expect, sometimes a head injury or things of that nature. And then a coma is when they're completely out. The brain is still, I'm not sure exactly because I haven't got quite into that yet. I know the body still works, but the person is asleep for a very long time. Sometimes it can be short of 6 hours, sometimes it could last years, sometimes permanently. We want to go ahead and assess the cranial nerves after we assess the level of consciousness with the neuro. I want to go ahead and go down of them 1 through 12. We want to start off with the olfactory, that's the smell. I've already sprayed some cologne on me prior to this. I've had it figured out. Will you close your eyes for me? Cover up one of your nostrils with one of your fingers. What do you smell?
Cologne.
What kind?
Fierce.
Fierce. There we go. She knows. All right. Could you do it with the other side now? Smell it there too? Okay. If she told me she couldn't smell it, I would ask things like, have you had a head cold? Has there been any trauma? Have you had a cough? Because that's something that we need to attend to and definitely fix. 2 is the vision. She is 20/20. She has no eyesight yet problem that we know of, but her last eye exam was over a year and a half ago. We know that we need to go ahead and get that assessed. But as I look at this, I want to go ahead and assess eye movements. I want to go ahead and say, can you read, there's a piece of paper on this. What does that say in that globe there on the table?
Forever.
Okay, I can tell that she can read and see because that's a kind of hard to see object. It's in a snow globe and it's about 8 to 10, 15 feet away. After that, we want to go ahead and move on to the 3, 4, and 6. That is the epitrochlear. That is the oculomotor, the trochlear, and the abducens. Now, how we check this is I see for all eye movements. I want you to follow my hand. No, keep your head straight. Okay. Okay, all eye movements are there. She didn't have any trouble. All eyes followed the finger without moving her head, so she has no problems with that. Then we want to go ahead and move on to the trigeminal nerve. That's number 5. When we check for the trigeminal nerve, shoot. The trigeminal nerve. This is always the one that gets me. Oh, okay. Yes, here we go. Trigeminal nerve. We want to feel the jaw muscle. We want to make sure that the muscles are contracting on the jaw and the temple. So I want to go ahead and test that. Clench your jaw for me. No, clench it. Bite down. Okay, I can feel them both. They're firm. We do it in the temporal area as well. I also feel them there. It's definitely tight. I can tell that they're working. Can you just move your jaw up and down for me? Side to side. Good. I can see that all movement's there. I wouldn't think there's any problem with the trigeminal nerve. Now we're going to move on to 7. This is the facial nerve. You can test this by just having them smile or frown. Smile and frown for me. Wrinkle your forehead. Smile, frown, wrinkle the forehead. Good. Everything's intact. Everything's good. On 8, that you can do a couple different things. I don't have the wine test to be able to click it to see the Weber test. So I'm going to go ahead and do a test with my fingers. Tell me when you can hear this.
I can hear it.
Okay. Look at the camera, please. Tell me when you can hear this.
I can hear it.
Okay. She could hear it as soon as I done it. You can also do a whisper test. Well, I'm going to go ahead and just show you how this could happen because sometimes they can't hear you. When we play the circle, when we say pass it along, always at the end of the circle, it's something different. So I'm going to whisper something in her ear and see if she can repeat it back to me.
We're going to Main Street.
She repeated it, heard what I said. Okay, now we're going to go ahead and move on to the glossopharyngeal and the vagus nerve, which is 9 and 10. I'm not going to do the gag reflex because I don't have any sterile sticks or anything, but I would touch the back of the throat and make sure that the gag reflex is intact. But I do so happen to know that she has a very sensitive gag reflex. When we brush the teeth in the morning, she cannot even handle the toothbrush. So, she has no trouble swallowing, but maybe to check this, I could hold the throat. Go ahead and swallow for me. I feel the larynx moving. There's no trouble. Did it hurt when you swallowed? Any trouble like that when eating? No, never has any trouble swallowing or anything. Okay, now we're going to go ahead and move on to the 11th nerve. That's the spinal accessory nerve. I want to ask you to shrug your shoulders for me. Okay, move your neck left and right. Look right and left. Okay, now I'm going to go ahead and check this as well. I'm going to apply a little bit of pressure. Put your face to the left. Okay, she can do that. To this side. Okay, we want to go ahead and check that and make sure that there's enough resistance to show that that the nerve is working properly and that it can also rebound, because that's one of the main things that we look for. The last nerve we're going to move on to is the hypoglossal. Open your mouth and stick your tongue out for me and keep it straight. Just tighten it up. Nope, straight out. There you go. Now don't try to move it or anything. Keep it straight. We want to watch for any kind of movements or any kind of shaking. My wife's having a hard time with this, so I'm going to go ahead and ask her to put her tongue back in her mouth. All right, and now we're going to go ahead and check a couple different things. We've checked all the cranial nerves, so now we want to check the reflexes to make sure that from the spine on down. This is usually associated with the cervical and the lumbar spine. I got to go ahead and grab my hitter. Now to check this is the brake. This is the bicep one. We want to go ahead and apply a firm pressure down here at the bottom and tap and feel for rebounding. Rebound is felt, and you can actually watch the bicep contract. Yes, the arm's actually moving. We want to do the triceps. That's on the back. And you want to do this by tapping your finger barely, not onto the patient, with the biceps and triceps. Okay, I also see the contraction on the triceps. You got to check down to the arm. We go down to the brachioradialis. We look for movement of the finger when we tap here on the C5, and we watch for the thumb to move out. Keep your hand there for me and relax. Okay, fingers moved. We want to go ahead and check this side the same as well. We want to check the bicep, and we want to look for any kind of contraction. It's noted. Check the tricep. Okay. And then the brachialis. Okay. We want to go ahead and move on down to the patellar. Go ahead and let your legs just hang freely, okay? You're supposed to be hanging off of a table, but we don't have one of those available. You're just going to have to take my word for it. But what you're looking for is when you hit the knee, you want to go for the bottom of the patellar bone right here so you can hit this muscle. Now once you hit the muscle, the leg should contract firmly out, okay? Now once we tap it, you can see that the movement should happen. 1, 2. I can see a jerk, and she is not trying to move it, and it's a stable jerk. Stable jerk on the left, even better than the right, so to say. Okay, then we want to go ahead and move on down to the Babinski reflex. She's not a child, so the Babinski isn't going to work, but we also want to check the bottom of the feet. I can't remember exactly what it's called, but you want to push the foot up. Don't fight me though, just let it relax. And then we want to hit the back of the Achilles heel, and you should watch for the foot to contract. Okay. Relax. Okay. The back of the Achilles, the foot should try to contract down, which is felt. The rebound is felt. I can tell all deep tendon reflexes are there. I want to go ahead and do a test real quick. We're going to ask how to do the discriminative sensations. Stereognosis is when we check for, let me go ahead and do this one. Hold on 1 second. Shoot. Oh, where's it at? Handy. Okay. I need 2 things really quick. Just wait patiently by the camera for me there. Okay. The way we test for the discriminative senses is that we can take for stereognosis. We take 2 common objects. Don't see them. Close your eyes for me. I'm going to say, open your left hand for me, and she's going to tell me what it is. What is that?
A charger.
Okay. To what?
A phone.
Okay. This is the stereognosis, like I said. Now go ahead and keep your eyes closed for me, and let me use your right hand. What is that?
My earrings.
Earring? Okay. She can also tell me what's in her hand without seeing it and tell me it's a common item. And once again, this is the stereognosis. The gaphathesia, I want to go ahead and ask you to hold your hand out for me again and keep your eyes closed. What number did I just draw?
7.
Yes. Okay. On the gaphathesia, you tell the patient to open their palm, you draw a number with a blunt force of a pen, a pencil, something like that, and you have them tell you the number with keeping their eyes closed. Now let me go ahead and you do a different number, and they have to guess the correct number, that way that you can see that it is all intact. Okay, she got them both right. We can go ahead and lay the pins down. No, I'm sorry, let me go ahead and move on. We're going to do the 2-point discrimination. I'm going to use a pin and a part of this earring for this. I want you to keep your eyes closed for me. Now, to test for this, you want to poke with 2 pins or a needle, and you don't do it hard, just enough where the patient can feel, and you poke twice. See how far in between. It should be less than 5 millimeters for the fingers. They should be able to feel 2 pinpoints up to 5 millimeters before they cannot discriminate against. They should feel also going between 2 and 1 and then guess the right one, so we're going to do this a couple of times. Okay, just tell me how many pinpoints you feel.
8.
No, I'm sorry, you counted them. Just tell me how many you feel one time.
1, 2, 3, 4, 5, 6, 7, 2.
Okay.
Sorry.
That's all right. Okay, she could distinguish the difference between the pinpricks. Now, and I didn't see it was about up to 5 or 4 millimeters before I noticed it. I want to go ahead and do one more test. I think I may have got it confused with the gaphathesia to the stereognosis. We want to do this right here as well. We want to check the fingers. Keep your eyes closed for me. You want to hold the sides of the finger, move the finger up and down, and the patient has to tell you which way they're going, okay? This is up. This is down. Which way is the finger?
Down. Up.
Okay, so it definitely does work. She could tell me that her finger was up or down. She didn't have to tell me anything else. Proprioception is Goodness gracious. Forgot what proprioception is. What is proprioception? Okay, proprioception. Hold on 1 second, give me a second, and I can go ahead and remember this. Oh, excuse me. I remember now. Proprioception was the finger. That was the up and down, the proprioception. The stereognosis was the identifying the objects, and the graphesthesia was identifying the numbers. So I did do all complete tests for the neurological. Did get a little mixed up. I think I hit the cranial nerves very good. I got the graphesthesia and the stereognosis and the proprioception, but I'll go over that one more time. The proprioception is the moving the finger up and down, using the fingers on the side and discriminating between up and down. Stereognosis is the identifying of the common objects in the hand with the eyes closed. Graphesthesia is the identifying the number as you write it on their palm. And the 2-point stick is to identify the patient when they feel 2 to 1 sticks, and they should feel the 2 sticks up to 5 millimeters in closeness before it's only felt like 1 on the fingers. That does it for my Nurse 33 final. I've had a great semester. I've learned a lot, and I appreciate everything you've done for me, Jeff. Thank you.